Good morning, good afternoon, and good evening, dear vascular surgeon, hematology, and radiology doctors all over the universe. It's our pleasure to meet you at the 10th webinar meeting titled Phlebology in the Real World. I hope you all enjoyed the promo of the first virtual conference in the Middle East. I hope to see and meet your avatars within the next few days. This will be a good chance to get together, meet, discuss what's going in vascular surgery, not by yourself, but your avatar. Please take your place and take it very fast, as the registration is limited for a little number for attendees. For more details, please contact the email info@agvasc.com. Now we start our meeting. Please, first, I would like to welcome my co-moderator, Dr. Omar Farouk. Hello, Omar.
Hello, Professor Ayman.
And welcome our speakers today, Professor Fabricio Santiago from Brazil, Professor John Chrisrak from Germany, Professor Victor Canata from Paraguay, and our great panel, Dr. Raul Jindal from India, Dr. Khaled Al-Qafas from Egypt, Dr. Angelos Quaderi from Brazil, Dr. Samir Kusai from Saudi Arabia, and please accept the apology of Dr. Erika Mendoza as she got ill, and let us all ask quick recovery for her. Now, I am honored to introduce our first great speaker, Dr. Fabricio Santiago. Dr. Fabricio is a certified vascular surgeon and certified sonographer too. He's a director of Venous and Lymphatic Disease Institute and assistant vascular surgeon of GG Hospital. He's an international member of American Venous Forum, V-Winter, and he is the committee coordinator of Brazil Society for Vascular Surgery and Venous Disease. Today he is going to discuss a very interesting topic regarding the sclerotherapy and transcutaneous sclerotherapy. I hope and I'm sure you all enjoyed the talk. Please, Dr. Fabricio.
Thank you very much. It's very nice to be amongst some virtual colleagues that I've met a few times and amongst some very dear friends just as Bravul and Rag and Professor Kanata. So I'm starting sharing my screen. Okay. Let me see here. Okay, can you see my screen? Not yet?
Yes, sure.
Okay, can you see my presentation?
Yes.
Okay, so let's move on. We were talking previously the transmission. I received the gift because when we're talking about the practice of phlebology in the real world, and we're talking about transcutaneous lasers. So this is something that I hope that after this presentation and as in the future becomes a reality in the most of the phlebologists or vascular surgeons daily practice. I have no disclosures. This is the logo of my personal research institute. And this is an acronym, as we know that laser, it's light amplification by stimulated emission and radiation, which basically is when we have an electron orbiting in the atom, when we perform a stimulation by electricity, by optical stimuli or thermal stimuli, we move this electron from this circulating orbit, and this turns the electron unstable. When it comes back to its normal state, then the photons will be generated. So all of these things usually happen in this small box that you can see here, with a combination of several mirrors and some lenses. We usually have, this is usually stimulated by electricity, and we usually have a lamp inside this small box, and this lamp stimulates the electrons and consequently generates the photons. We have, when we open the cavity, then we'll have our laser beam. So this usually happens in that thing, that little pistol that we have, that is the manipulum. So we now have the laser, so we have to know some basic properties. Laser is always monochrome, just one wavelength. The lasers, they are coherent. The photons fall in unison with the same peaks and the same valleys. And the lasers always run into parallel rays. Okay, now that we have the laser, we have its basic concepts. Now we have the structure. We have to talk about our target. So our target are the vessels, which are located in different parts of the skin, in the epidermis or usually in the reticular dermis. So this is our target. To reach this target, usually when we generate the laser beam, after entering in contact with the blood, which is the absorber, and then a heat is going to be generated by the transformation of the chromophore, which is the blood, into heat, damaging the wall in a temperature that should be 70 degrees Celsius, preferably. This is the temperature that we should reach. And for doing that, we need basically 4 mechanisms or 4 things so that can occur. We need a proper wavelength with a proper spot size given by the manipulum, a proper energy that when we energy is it's in joules, and fluency is divided by the spot size, and the pulse duration, which is the exposure time that we're going to give the structure. And this is the basic principle that we have to keep in mind. This is the selective photothermolysis. And I need you to pay attention to the chromophores. So we basically have 2 chromophores that we need to pay attention. It's the melanin and it's the hemoglobin. And we can see here, for an example, with lower wavelengths, we have a very good absorption of, for an example, of oxyhemoglobin, but at the same time we have melanin. When we increase the wavelength, this absorption by melanin decreases and also decreases the oxyhemoglobin. As we can see here, the NDI, the 1064 nanometers, although most of the people think that it's a good wavelength for oxyhemoglobin, it is not. But the problem is that it's not good also to melanin. So we have now choosing the wavelengths. We have several different wavelengths. We have the visible ones, the KTP, the pulsed dye laser, the intense pull light, which is not a laser, it's a light source. They have a good affinity for hemoglobin, and we can treat small targets with less energy. The problem is we cannot treat larger or deeper vessels because those lasers, they are too superficial. They have good affinity for melanin. This is a problem because we don't want to reach the melanin, especially in high Fitzpatrick skin patients. So the infrared, this is the wavelength that we basically are going to talk today. We have a good, not so good hemoglobin absorption coefficient, but it can treat larger and deeper vessels once it goes deeper into the skin. And it allows to use on higher Fitzpatrick patients. So regarding the depth, it's very important. As you can see here, the 1064 is one of the transcutaneous lasers that reach the deepest level. This is very important because we can reach the reticular dermis and sometimes the subcutaneous tissue, depending on the patient's fat. And we have to know now, after knowing something about the wavelength, the interaction, the tissue interaction. So when the laser interacts, reaches the skin, it causes basically four phenomena. It's the reflection, it's the transmission, and after this transmission, the absorption or the scattering. The scattering is one of the most important things to know right now. So this is the Monte Carlo simulation. It's a mathematical model. It's very well known. And when we see here this simulation of photon migration on the wavelength of 630 nanometers in esophagus tissue, we can see this area, which is the convection zone. When the laser reaches the tissue, it creates a convection zone. It is the higher effective fluence reached by the determined wavelength and the determined spot size. The larger the spot size, usually we can have a higher fluence concentration, and the higher wavelength, we have also a deeper penetration of the, such as the laser beam, as the generation of a higher effective fluence. This is very important when we're talking about choosing the spot size and also choosing the wavelength. As I mentioned before, the 1064 is the transcutaneous laser that reaches the deeper layers. So, but regarding the depth, it doesn't matter if we increases the beam diameter. In some point, we won't have deeper penetrations because of the tissue interaction. It doesn't matter if you go to 12 millimeters, 14 millimeters, this won't change anymore, okay? And the other parameter is the pulse duration. It's the exposure time that we're going to give to our structure, to our target. It's calculated using the thermal relaxation time, which is the time taking to the structure loses 50% of its temperature. And we have those, we have those parameters, usually for red cell telangiectasias, the thermal relaxation time is from 10 to 12 milliseconds. For blue ones, 12 to 30, and reticular veins to 30 to 60 milliseconds. It's important to notice that 10 milliseconds is a thermal relaxation of the skin. We should avoid this pulse duration. So regarding the literature, we could spend the whole afternoon here talking about different publications regarding 1064 or other wavelengths for treating veins, but we're going to mention this specific guideline, which is the European guideline from the European Society for Laser Dermatology, and we can see that for different lesions, we have a high recommendation grading, some of them with a very high level of evidence. For an example, for treating leg veins. Yes, we have some complications. The lasers can burn the skin. The lasers can cause hypo or hyperpigmentation. They can cause purpura. This is one of the most undesirable effects, which is the pain. It's usually painful. This is a personal archive of mine, a patient where I did, my stuk was stuck in the pedal. So I gave her 2 pulses, one after the other. I have burned the patient's skin. This is something that can happen. And for avoiding pain and also avoiding those complications, especially the burns, we need to cool the skin. So this is something that is mandatory. By cooling the skin, we can also minimize the pain of the patients once we already have some publications regarding that. When we cool the skin, we have some very good results regarding minimizing the pain. This is an example of patients with periorbital and lateral temporal veins. They were treating, this is another possibility, sorry, to use topic anesthetics. This is a paper published where the authors, they compare the placebo on one side and the other side, lidocaine gel at 30%, and they have a significant difference between the side that was the gel, lidocaine gel was used, favoring the use of topical anesthetics. And this is some things that we use in the office occasionally to perform facial veins with very good results, with the side effect that it causes some hyperemia on the skin. This is not a good thing. This is the second one. The second one that we can see here. It causes less hyperemia, and we have some contraindications. Of course, it should not be used on pregnancy or on open wound, skin, or infection. Of course, we're not talking about stimulating the tissue in open wounds, but for treating vessels. In tended skin, the use of ferric supplements, we should take extra care. Photosensibility disorders, hypertrophic scars, or preview herpes on the area. It is very important. The professional should possess competence to diagnose the patient's cutaneous vascular disorders. This is a basic, and especially deliver safe and appropriate laser or intense post-light treatments by knowing the basic phenomena and by knowing what he's going to need to deliver regarding the optimal parameters. So in summary, this is not a toy that we can play with. So for different veins, we should have different parameters. In our left, we can see a small vein. We usually for that use smaller spot size. Once we need the energy, goes to the surface. But on the other hand, we can see a very bulging vein here in the face. We should use a bigger spot size, a larger spot size. On the other hand, regarding pulse duration, according to the thermal relaxation time, we should use shorter pulse durations. On the other hand, for larger structures, we should use larger pulse durations according to the thermal relaxation time. So the energy, we usually, for small structures, once we're in the surface, we have more scattering. So we have to compensate the loss of energy. We should use more energy. On the other hand, for larger veins, we should use less energy. Of course, we're talking about the 1064 nanometers, especially. Okay, some situations from regarding lower wavelengths, this can change. Regarding the pulse frequency, this is something that we do not mention a lot, but this is you surely will see in your devices. When we use treating small veins, we have a tendency to use higher frequencies. On the opposite, for larger veins, we use less frequency in those patients. So this is an example of monotherapy in a patient with a reticular vein, and we didn't inject anything in these patients, in this patient's leg. So using those parameters, this is the immediate result. As long as the patient tolerates the pain and the use of those parameters, we'll have very nice results. On the other hand, with some situations that we have larger veins, we usually have this result. We have this appearance of some spots of the vein, and in this situation, we usually can inject a very small amount of sclerosant agent. In Brazil, we usually use the dextrose, and this is a very important thing. This is a very expensive device, so before buying these devices, you should take into account a lot of things. The return of your investment according to time. And if you think this return will be too long, maybe do some partnerships in dermatological clinics, buying with other phlebologists or with other vascular surgeons, so that your investment can return to you. And especially, don't use the only tool that you have. I'm going to explain you why I'm telling you that. You have a multi-use tool. So my advice, if you're buying to treat only leg veins, don't do it. You should know how to explore the laser well. For an example, treating facial veins. So it is very common, the patients come to my office to treat leg veins, and during the treatment, the patients themselves, doctor, I have some telangiectasias in my nose or some facial veins, could you treat it? Yes, I can treat them. In this case, usually dermatologists do the treatment. I can do it in my office with very nice results. This is a facial vein. You can see the very good results obtained. This is just one session with those parameters. You can see a very nice result. And the 1064 also stimulates collagen. It's not the best one. Cherry angiomas, this is something that is very common in my office. The patients usually ask us to treat cherry angiomas. And we could spend the whole afternoon mentioning other examples, just like capillary angiomas, and in some situations of deeper capillary malformations, we can use the 1064 as well. Venous lakes in the mouth, in the lips, or in mouth, we can treat them. And this is something very important. We are working with a very, very recent technology. Charles Towns performed the laser in his research laboratory only in the 60s. And the theory of the selective photothermolysis was published only in 1981. So this is really, really recent. We've been learning a lot from it yet. And this is what we've been working with. Of course, that we still work with the thermal relaxation time, but this is the tendency to work with the Arrhenius thermal damage equation, which takes into account the total accumulated tissue damage, the frequency that we deliver the energy and our main target, and the frequency that we do denaturation of and decomposition of those structures. And I'd like to invite you all to participate from the Food for Veins project from the UN. It's going to start on Sunday. I'm going to give my collaboration by talking about treatment of telangiectasias using laser, and we are going to talk about different and different wavelengths to treat them. May the force be with us during this pandemic. Thank you very much.
Thank you. Thanks, Fabrizio. It was great. I think you make the difficult thing very clear and easy. And this is will give us a great time and opportunity to discuss and ask more and more. Nice presentation, in fact. Let me start by Raul. Do you use the same parameters, Raul, for thermal calculation in treating telangiectasia and reticular veins?
Yes, actually talking, I agree with nearly all the parameters, except for one problem. What we faced in an Indian population was, when in the beginning we were all trained from the books and everything. You need to work on thermal relaxation time. PRT is the most important thing to understand the basics, how much you're going to use the pulse duration for. The millijoules, the energy given. I really don't know. Most means nearly more than 90% of my patients, they are not able to tolerate more than 60 joules. And some actually even not able to tolerate 40 joules. So what I learned from that was, what I do is, initially I had real great difficulty. So what we have learned is the stacking. So what we use is, we do two passes. So like if you want to give 80 to 90 joules, and the patient is not able to tolerate so much energy, so I'll give 40 joules, then keep on passing it, and then another shot with 40 joules. And so that is, this way I can deliver the amount of energy what I want. Like most of the places, Dr. Fabricio showed, like he used 80, 90 joules. And if you look into the literature, if you look into the same European guidelines, some of them, they mentioned using 130 to 140 joules of energy. And really, it's impossible. Most of the patients, they don't tolerate. I think maybe because of the dark skin, but I really can't explain with the laser physics why.
That's good. This is a very good point. Can you explain, Fabricio, this
No,
point?
Ravul made a very nice comment, especially regarding the pain. I totally agree with you, Ravul, regarding the parameters that are published. I truly don't know how do they do that. So this is something very strange.
That's good. That's
regarding,
good. Yeah.
Regarding the second pass, I totally agree with you, but hi, Rag.
Hi, Ray.
Hello, my
How
friend.
are you?
So I wouldn't advise to give one shot immediately after the other. So you increase the chance of so you could do an overlap, which means that you give a shot and immediately after, in a very near distance, give another. But one above the other, this is something that I really do not advise you to do.
No.
So
what
regarding
I do is, I just pass it to and then start from again by the time some relaxation time is totally gone.
This is perfect. And there's another thing, Ravul. This is something that the colleagues, they're starting to do it. They can observe this. Sometimes you can do a very good calculation and the patient tolerates. But despite of that, when you look at the vein using transluminescence or augmented reality, you see nothing. Wait a little. 5 or 10 minutes after, you can see there's a spasm. You don't need to be rushed. Otherwise, you're going to burn the skin of the patient. So occasionally, especially in the legs, this is something that usually occurs. It happens. When you pass this with low fluencies, sometimes we inject a very little amount of sclerosing to, this is the CLACS technique, actually. So it's better than you insist on having the result passing once, twice, or 3 times, or even increasing a lot the fluence. Okay.
Yeah. Excuse me, I want to ask, in doing both injection and laser, you inject first, then do laser?
Actually, I need to work with the chromophores, so I need blood. I do the laser, and then after, we know that we have Moreno Moraga's publications using, actually he's scattering the laser beam by injecting foam, and then after that, doing the laser. This is, they have very nice publications regarding that. But regarding my practice, I prefer to pass the laser first using the chromophore that I need. And after that, if I think that is necessary, I'm going to inject.
Great. Let's ask Dr. Scuderi. Dr. Scuderi, what's your comment about these thermal parameters and the technique of Fabricio? You have a comment?
Well, I'd like to make compliments from my colleague from Brazil for a nice presentation. Well, I have not a great experience with laser. My experience is few because I prefer to work with a few parameters and I don't mix too much techniques. I I treat all kinds of vein with this fun. I think the fun make a revolution in phlebology because it is very cheap and very effective if you work well. Well, I think the laser is a good technique, but as the authors say, is expensive, and we need to have one environment appropriate to have this kind of device. Otherwise, you have no possibility to work with this.
You have right, and you have a point too. Dr. Kanata, I think you have a very nice experience of laser, and what you want to add for this talk? Dr. Kanata, you have to open the mic. Dr. Kanata, open the mic, please.
We can't hear your voice. We can take opinion of Professor Samer Qusayr until Kanata correct his mic.
Thank you, Omar. I really appreciate that.
Yes.
I mean, very nice presentation by Dr. Fabricio. I really enjoyed it. Unfortunately, we used to use a laser a lot, and then we switched to radio frequency, and now recently we switched to venosil. But when we use a laser, we use almost the same parameter you use, and we have the same reservation that if you go more than 60, really patient very hard to tolerate it, But my question, which is really the second debate, when you do that, do you do really flush, ablation of the saphenous vein, or you go about 2 centimeters from the saphenous vein junction? What's your technique? I know this is the second debate we'll do through it, but I'd like to get your feedback. What's your practice from the saphenous femoral junction?
Yes.
Do you flush ablation, or you go away for about 2 centimeters?
Let's wait, please, Samer, let's wait. We'll discuss it in a very big comments. Let's wait for that. Now we'll keep for transcutaneous laser.
Yeah, Professor Khalid Al-Affas, I think, have a comment. Professor Khalid.
Thank you, Dr. Fabricini, for the very nice presentation. I would like to ask if you have a patient having saphenous reflux, maybe, or extraaxial varicosities, and he is also suffering of telangiectasia, lateral thigh telangiectasia. Would you perform both in the same setting, or you wait a little bit after, or some time after doing the ablation or abolishing of the venous reflux?
Actually, you mentioned the lateral part of the thigh, where usually we do not have contact with the saphenous trunks.
Yes.
But if we have a complex telangiectasias, Brazil, this is our definition. The telangiectasia which is connected to a reticular or with the varicose veins, and then with the saphenous reflux, I treat first the truncal reflux. In Brazil, we have a very common practice, which is to treat saphenous veins, to treat tributaries, and at the same time perform sclerotherapy. This is my PhD thesis, even with spinal blockage or with under local anesthesia, but not using transcutaneous lasers in those situations. I usually perform transcutaneous lasers in the office only to treat reticular veins connected to telangiectasias. If there is any connection with an insufficient saphenous veins, I do not advise to perform transcutaneous lasers on those veins, because you won't have a very nice result.
Okay, thank you. Thank you.
Okay, Fabricio, let me ask you, do you have a limit for the maximum energy they use for treating or for using transcutaneous laser in one session? This
is one of the greatest advantages of laser. We don't have limits. The only limitation is the patient's pain. If the patient is tolerating the session, you can use the transcutaneous lasers all along during 1, 2, 3 hours. There's no limit for that. The limit is your experience and the device that you have, and also the patient's pain.
Yeah, I agree. Let's ask Rag, what's your experience or what you want to add in using transcutaneous laser? Dr. Rag.
First, I apologize for being late to this meeting. We had a time error, so sorry for that. Transcutaneous laser is a nice tool, but the energy has to pass the skin. And we do not have a real focused modality like we have it for the focused ultrasound. So my experience is that wherever in the world I saw people do effective laser, it hurts more or less, and rather more than less. Even in Brazil, even in the places where all the very, very famous Klux enthusiasts are working. And so this is a technical problem we have to solve. Cooling alone is not the answer, because cooling will constrict the vessels, and somehow you need a certain size to hit the target with a laser. So it's a nice idea, and we're doing Klux also. We are doing research on it, but it's an intermediate stage where I hope we will do much progress in the coming years.
Great. Welcome, Dr. Kanata. Are you ready to talk now?
Can I answer to
yes, sure,
Rag's
please.
comment?
Yes, please.
Rag, I totally agree with you regarding the pain. Do you have an experience with nitric oxide?
Well, actually not. I heard about it. What give us your opinion on that, please?
I think this is gonna cause a revolution in pain, because we've been having very nice results with it.
I agree.
It's a very nice tool.
Okay.
Very safe sedation. It minimizes the pain a lot. And let me ask you something back. Something regarding HIFUs. There's no pain using HIFUs?
Well, I was just addressing the principle of focusing energy. I'm not a believer in HIFU also. It's a good perspective, but we will need 10 more years to get it precise enough to hit the target without inducing so much pain.
Yes, this is something very interesting, because every time that we're transforming a physical parameter, radio frequency, light into heat, it's gonna heat the water around the tissue. It's gonna cause pain. Anyway, frequency, light, it doesn't matter. So probably it's very hard, unless you do some kind of anesthesia, injecting or by sedation or something like that. Or in my case, I do a lot transcutaneous laser. I'm usually very delicate by doing it, respecting patient's tolerance. So by doing that, you usually can't do it. But without pain, this is something that is yet to come. I agree with you.
It's also an individual compromise. I think you in Brazil, your patients, they expect immediate.
We are losing audio.
Open the mic, Rag.
The mic.
Yeah.
In France, for example, patients are very patient. They don't know the laser. They know sclerotherapy. They know if there should be results, it will take months. So there is a different culture, and my clinics are in the middle. We are using less laser than you do to reduce the pain, and we demand a little bit more patience from our candidates.
Okay, let's go for Dr. Kanata. Victor, please.
Okay, now I have my mic on already. Thank you very much. Fabricio, you give us an excellent lecture and excellent point of view. Yes, we have to have two kind of consideration. I'm thinking about one thing first. No pain, no gain. And you have to remember, the ladies who came to my office, they are aware that they want to have something to be done. And if you tell them that they will have to go through some kind of pain, they will be more than happy to tolerate without trouble. If this is the problem, ladies, if you tell them your legs will improve, the vein will disappear, how you will do it? I will get a hammer like this, I go to your leg like this on one side to the other side, and then the vein will disappear, and she'll say, I will tell her yes. And then she says, thanks, doctor, let's do it. And this is 95% of aesthetic patients that we have all over, in Brazil and in Paraguay. The ladies want to go to the beach, they have a hot weather, and they want to go for the summer, showing their body and doing all the stuff always. And this is a big difference that we have in South America here. And that is the reason that they came to our office. We offering them a new kind of treatment, a different treatment, and they have good results. We are not just trying to burn the whole skin. We are trying to numb just a little bit with ice, or maybe with the Freedom machine, trying to just give enough amount of power, trying to just make the vein disappear, and we have very good result with that. And this is the final idea. The final idea is, in your office, you have to tailor everything, all the tools. You have to have one no laser treatment and one laser treatment. Both of them, if you're tailoring very well, you will have very good results. This is my point of view. And the patient came for more and more after you show them that they are improved, besides of the pain.
Yeah, you have a point.
Let me answer the comment, please.
Yeah, sure.
Professor Kanata, nice to see you again. So why don't you, instead of doing like this, you just don't do like this? I think it is better. This is my advice. And secondly, in my office, comfort is something that it's totally mandatory. It's very common, the patients suffering from pain. The patients tell to another patient, oh, it's too painful. Let me try something else. This is very dangerous. So in my office, comfort is something that is mandatory. If the patient does not tolerate, I can change the technique. If you're using a laser or if you're performing sclerotherapy, it is the same thing. If you have a heavy hand by doing sclerotherapy, the patients, they're going to feel pain, and then they're going to tell to the other patients that it's too painful, they are not coming back. So in my private practice, and also to my residents, comfort, this is something that we usually tell them that it's totally mandatory. By using the cooling systems, by using local anesthesia if necessary, by using nitric oxide, it doesn't matter. Most of the times we don't need to use anything, just by giving, by doing the procedure with a lot of care, no rush. This is something that I keep telling everybody. To perform aesthetic phlebology or even phlebology, you need to give patients total attention and especially time.
Okay, I agree for that. You have to be very patient and very delicate for dealing with the patients. I think Dr. Scuderi wants to ask a question. Please, Angelo.
No, Dr. Rag leaves. Dr. Rag, come, please. I just want to make an observation. Brazil is a very big country, is a continent. And we have a lot of educations. No whole do the same. I'd like to point out this, because there are a false impression that we work with static. It's not true. There are some doctors, they work preferably with static, but not all. This is very important to point out. There are other doctors in Brazil, phlebologists, vascular surgeon, have another point of view. But the point of view of Fabricius is very important because Brazil indeed is a hot, warm country. The women's like to show her legs, and the aesthetic is always important, but not the first one. We have a lot of the opinions.
Yeah, sure. It is big country, yes.
Yes.
I think Raul wants to add something before I give the mic to Omar.
Yeah, you know, the most important point, you know, Fabricio have made in my clinic, if the patient has pain, actually in the beginning of my, you know, when we started the aesthetic practice, one of the patient actually got up from the bed and he said, no, thank you. Though I was very gentle because I was just using the juice, which was 50% of the written juice, because even 70 joules people were not able to tolerate. So I think, you know, I totally agree with you, you know, in this, especially aesthetic transcutaneous, I try that the patients are really as less pain as possible. If the patient is slightly nervous beforehand, now we are using, you know, on the skin, lignocaine, 10% creams we are applying half an hour before, and we keep them and we clean it up later on before we do the laser. And around 50 to 60% of the pain gets down. And especially if you use 27 to 30 gauge needle for injecting the sclerosant later on, patient actually doesn't feel pain at all. So I'm not using it in all the patients because it takes a lot of time. But patients who are nervous, some group of patients, it really helps. Though not 100%, but you know, but I think in this aesthetic, pain is very important to monitor.
Yes, pain is very important. Please, thank you all speaker and the panelists. I give the mic to Omar.
Okay, and
Carry on, dear.
I don't have a question, but I can see Professor Kanata is eager to have a comment. If you like to open your mic and give us your nice comment, Professor Kanata.
I make all the women suffer in my office here. That's the only thing that I want to tell them. Thank you.
You're welcome. I'm sure they don't suffer because you have very busy clinic and we all have seen your fantastic result. I think it was a great lecture and a great argument with the great leaders of the venous intervention worldwide. Thank you very much, Fabricio, again for such a great presentation. We'll always welcome to our platform. So the stage is ready, Professor Ayman, for the great debate. So Mike is back to you, Professor Ayman.
Okay, thank you. Before we start the debate, we'll put the question for polling. This is the question: ablation of the great saphenous vein at the level of the saphenofemoral junction or at the femoral vein level is a safe procedure. Number one, yes. Number two, no. Please vote. Waiting for results. It takes about 15 to 20 seconds. During that, yes, about 70% thought this is not safe to go to the femoral vein and gave hard time to RAG. And now I am honored to introduce my dear professor, John Chris Rag. Dr. Rag is a double qualified. He's graduated from Faculty of Science and Faculty of Medicine too. By the year 2003, he founded the famous clinic in Germany and in Europe, Angio Clinic and Vein Center in Berlin, that became the most specialized center in Europe. As a matter of fact, Dr. Reg can do more than 250,000 case for examination, and about 100,000 office-based procedures. Dr. Rag is international member of American Venous Forum and American College of Phlebology, and European Venous Forum, and International Union of Phlebology. Dr. Rag will going to discuss the ablation of great saphenous vein as close as to the saphenofemoral valve. Please go on, Rag.
Dear Ayman, thank you very much for your nice introduction. It's indeed, it's not easy to characterize me because I did so many things in my life. For instance, I studied physics to a diploma, and I did so many things which really are of benefit today, but it was not the straight course of becoming a physician. I will try to share my screen with you. And my question is if you can see the screen.
Not yet.
Not even yet. Now? Yes, one click more. Can you see?
Yes.
That's fine. So I was given 10 minutes for an update on vein ablation, and in particular to answer the question, is it safe to do ablation from femoral level? Later on, I will ask you if the question is fair. First of all, let me show you from where I am talking. This is the nice city of Zurich, Switzerland, with the highest density of millionaires all over the world. And this is my team, and on the right side you see my dog, and it's a nice place, and we're doing a fancy job here. We are advertising with the slogan vein healing instead of vein killing. And so this might indicate that ablation is not the only word I can spell correctly. So it's far more I'm after. Recently, we had a nice discussion here in this forum with Dr. Kabnek, and so during this discussion, I said a number of nasty things. I said it's not about a safety distance, it's a coward distance. And I said there is no EHID with proper technique. And I say that the only important aim is to establish laminar flow. I think everybody got me wrong. I was not talking about straight femoral closure. I was talking about a hemodynamic phenomenon. And if I favor anything concerning ablation, it's this. Treat only segments with insufficient valves which cannot be restored. Destruction of endothelium, that's clear. I believe in precision. No matter where you start your closure, your ablation, it should be precise, and there should be maximum patient comfort. And overall, I think I have to start with explaining what I mean with laminar flow. So whatever we think about methods and anatomy, there are general laws. And we know that a flow which is laminar will have no turbulence and thus less shear stress. This is from my physics lessons. You see this. We know from several publications of basic science that shear stress on veins is a definite cofactor of valvular or wall degeneration. Second, we don't want no turbulence in aspects of low flow zones because they could form a risk of thrombus formation. And you see the drawing down, and if we are closing a tiny saphenous vein for some reason like this, we should have a 100% flushing by the epigastric vein, which works when this one is very, very large. in other situations, we have totally different relations, and the right side gives us a problem. If we close the GSV even below the epigastric vein, how shall we stop? Like this, for example? Or should we do it like this and wait for a thrombus to generate here and to help us to get a laminar flow, which will sometimes happen? Or should we go for hyaluronan narrowing and shape a way we want to have it for laminar flow? So I don't have all the answers, but I know for sure that creating laminar flow, independent from which level, is the physical answer and the best protection against recurrency. Now, we are thinking that thermal device is the most precise, and that's what I believe. It's more precise than foam, it's more precise than glue, and of course I favor these nice straight results because they resemble the best job our surgeons could do in the past century. That's what they wanted to do. No stump, everything flush ligation. And if they thought it was good, it cannot be so wrong. And by the way, we had a publication even in 2012, 8 years follow-up, creating this kind of closure morphology. We almost had zero recurrency from the groin. Well, I don't believe in all the other methods for the groin, even if I invented them, like the miracle biometrics sclerofoam. Within a straight vessel, it's equivalent to laser, but not at the groin because it's a foam. It's not precise enough. I don't believe in gluing for the junction because it's difficult to place on the millimeter, although it's a nice idea behind. Once it's cultivated, it will do a lot of blessing to us. But at this moment, it's imprecise and it has to be aggressive, so that's not the choice. Currently, I'm working on a combined method using slim radial laser fiber for the junction and combined foam and point-wise gluing. This will be in the approval study next year together with a French company. And of course, with this method, we have a flush ligation-like closure at the groin. Now, let me tell you a funny story. In the beginning, I was all alone in Germany doing laser. I knew nobody in the world being in front of me because usually somebody is further advanced than you are. And I simply did not know how to do the laser and how to do the tumescent anesthesia. And I developed my own ideas. I thought we should have a small needle, not to hurt the patients, and a long needle to go coaxial with a vein to prevent incidental puncture. And I did it manually, not with a machine. And 5-6 years later, we learned that the rest of the world was doing it different, using larger cannula, put the cannula somewhere in the area of the vein, start the infusion machine, and wait for the result. And so since this was the only difference in our 8 years follow-up, same laser machine, same patients, anything else was same. Since this was the only difference, there's no other explanations why we did not see any larger number of recurrencies. It was below 6 or 7% over 8 years, which is almost nothing. So sometimes small differences in techniques may have large impacts. Now, let's have a close look. What is the problem with the saphenofemoral junction? The major problem is that we do not do a proper analysis. And we realized this a couple of years ago. We were simply missing the AAGSV structures. We did not watch the valves. We knew nothing about this vessel. So we did a study to determine the anatomy, and we found that for above 92%, the entry of the epigastric vein and the AAGSV was closer than 3/4 of a centimeter. And so there was little difference in distance between those two anatomic situations. And we thought that not caring about the AAGSV might transfer some pathologic pressure from the open stump to this vein. And so we performed the comparative study I mentioned recently. So 240 consecutive patients, all with healthy AAGSV for GSV treatment. Half of them starting at femoral vein level and half of them starting below epigastric vein entry. Same laser, same technique. We have the colleague from India within our site. I can see you at this moment. You mentioned some signs when doing the laser energy, and that's what we did in the study. We applied the energy according to criterion waiting for the onset of minor wall disruption, but it was the same for all the procedures. That's just to give you some honor for the comment you made some weeks ago. And this is the coaxial anesthesia technique. You see, we are really going in the same line in parallel to the laser, parallel to the vein, until the entry of the GSV, and we are doing a placement of anesthetic fluid there. And there is so good insulation if you do it in this technique that there is just no chance for any thermal damage. And that's what has been the contents of several posters and presentations I did in the past. And you see, it depends on the tool, on how it emits the energy, but you always have the correct insulation at the femoral entry. That's all. If you do it, we never had EHIT. In the first 12 years, we did not know what it is. And that's due to this technique. Now, in the study, we could obtain closure in all cases, but with very different morphology. We did not have EHIT, of course. And the morphology is explained, stump or no stump, by where we started the ablation. When starting from femoral level, almost all the cases had a nice closure of the AAGSV entry. And after 2 years, you see the result. You see AAGSV reflux just in 4.2% of the cases where we attempted closure at femoral level, but you see 21.7% when laser was started below epigastric level. So frankly speaking, we have a 5-fold increase of AAGSV reflux when performed with a safety distance and no particular case selection. The other question is, for let's say 100 patients, is there any justification to exclude 80 healthy AAGSVs from normal circulation to save 20 from potential insufficiency? You have to answer that question. I'm not sure. If you give me 2 more minutes, I will finish with a view to the future and the real answer. We did a large venous valve study, including more than 15,000 video documented single human valves. And we could find out that there are 3 totally different mechanical causes of venous insufficiency. And they all 3 lead to reflux. And they are very, very different. First, we have embryonic valve lesions, which have 3 different appearances. And they are rather frequent. They are seen by 30 to 40% of the children at the age of 6 to 10. They are there. And since these kids have done nothing wrong, we are sure they are there during the embryonic phase. Have you ever asked yourself why so many appearances in our patients are asymmetric? So these lesions appeared by incidence, and they well explain the totally asymmetric features we see in our vein patients. This is an example I did last day, just yesterday, a genesis of the terminal GSV valve. In a 13-year-old girl, visible manifestation 2 years ago. So progression might be very fast, even in children, if it is congenital. Second, we have pressure-induced valve decompensation. It's very easy to understand, and it's very, very unique to see. You see this every day. Now you will know it's pressure-induced. There is no other mechanism behind that. And finally, we have the stasis-related valve degeneration, which takes decades from the first adhesion of particles to the total destruction. We distinguish 6 stages. You don't need to see all the details, but there are clear criteria which mechanisms are valid in an individual. We never had this situation before. And now you will ask yourself, what is the impact on dealing with the saphenofemoral junction? If the lesion is there by incidence and not by increased local pressure, you are free to do whatever you want. You can do femoral level closure or closure below. It will be of no difference. If you have an increased pressure as the agent to destroy the terminal GSV valve, for what reasons whatsoever, heavy worker, no iliacal valves whatsoever. If this is the case, it depends very well on your strategy, and you should close at femoral level to protect the other branches, because you will not eliminate the cause. The pressure, increased pressure will be there, and if it has damaged one valve, it's just a matter of time. It will reach the next valves. So I think femoral closure is right in these cases. And third, if it's due to stasis, again, you're totally free. There will be no difference in which plane you do your obstruction, your ablation, if it is done with maintaining the correct non-turbulent flow. So this gives us the most actual access to what we should know about this location. It is not the one level or the other level. I just can say femoral level closure is safe if you use the technique I propose, but it's by far not the simple one solution. We have to know the local reason for the disease and the local anatomy. So that's all I want to say. Thanks for listening so carefully. And if you want, note our hybrid, our online workshop in November, where we will show the details of the technique and invite you to be at our side and ask all your questions for the practical aspects. Thank you very much.
Thank you, Chris. Now we have to go to dear Professor Victor Caneta. Victor Caneta is a professor of surgery and professor of human anatomy. Is a vice president of International Union of Phlebology. Can you hear me?
Yes, we can hear you. And I would like to welcome Professor Antoniani joining the panelist team.
Welcome, Professor Antoniani. Okay, going back to introduce Dr. Caneta. He is a president of Phlebology Society of Paraguay, and he's a vice president of Phlebology Society of Pan America. As I said, he's double qualified too. He's a professor of human anatomy and professor of surgery, Universidad Nacional de Asunción, Paraguay. Now he's going to put his point of view in the other face of the coin. Please, Dr. Caneta, the mic is yours.
Okay, let me open my mic. Okay, thanks Ayman and Omar to just let me do that special lecture. And this is the way that I feel when I will do a laser vein treatment. Since 2005, when I went to the Rio de Janeiro World Meeting of Phlebology, who was the president, was my dearest friend, Angelo Scuderi, I've find out about laser. And since there, I get the magic, and I find out that this is almost the best treatment for the small saphenous vein and the large saphenous vein. And the question today is, will you leave the laser fiber in the saphenofemoral junction in an AVLT treatment? And this is how we're supposed to feel when you are talking about something else that is strange to our feelings and in the way that we are working on a daily basis in our office. I don't have conflict of interest, and I've been working in my office for so many years. And this is just to remind me, what is the laser ablation? Laser ablation of the gray saphenous vein is a technique whose use has expanded dramatically. During the last few years, endovenous technique without groin incision and high ligation are certainly less invasive than conventional vein stripping and seem to involve less risk of neovascularization. From now on, from that time, we are moving and we are trying to show to the world that the laser treatment is a safe treatment, but that we don't need to open the groin, and the results are very good. This is one talk for one of my friends, Dr. John Muriello. In 1999, he talked that the endovenous laser ablation has changed the way that we treat the reflux saphenous vein. And in USA, and also is coming to the whole world, we are witnessing a dramatic decrease of the number of ligation of the stripping with increase of the number of intervention using the laser. And this is the way that we work. We are trying to show to the people how is the work to be done. This is the laser fiber. This is the saphenofemoral junction. This is the laser epigastric vein, and this is the fiber. We leave the fiber in that area 1 to 2 centimeters behind to the saphenofemoral junction and near to 1 centimeter from the laser epigastric vein. This is the way that we do the procedure. This is the way that we conquer our patients, and this is the way that we have to do the treatment. How is the way that we're doing it? We are trying just to show the way that we're doing it when we are trying to achieve a best result. We are going to the groin, near to the groin. We just get the sonogram, and with the sonogram, you obtain a longitudinal view of the saphenofemoral junction. You advance the catheter until the tip enter the image, and then you position the catheter 2 to 0.5 centimeters distal to the saphenofemoral junction. This is a schematic view. You have the catheter, the vein, the saphenofemoral junction, and this is the proper way that we're supposed to just leave the catheter in position before we fire the leg. What is the final tip position and verification? The recommendation is 2.0 centimeter distal to the saphenofemoral junction. You have to check the position with your ultrasound, and in two ways ultrasound. First in the transverse view, and then in the longitudinal view. Take the measurement and verify the distance, then you fire your laser. This is another view with that kind of different, the radial fiber. The radial fiber is just a little bit different than the wire fiber because it will give it to you just a less amount of energy at the tip of the fiber. You will just have the energy at the side. This is the way that they're working with the small green fiber. This is a video when I show how we work with the After we get the saphenofemoral junction with the fiber, we went to we saw the lesser epigastric vein, and then we will release the catheter 1.5 to 2 centimeters from the saphenofemoral junction to make sure that the catheter is in place and without big trouble before we start firing the laser. The other tricky stuff is when you do the anesthesia, you have to make sure and be careful when you are fixing the catheter. Sometimes when you are trying to just give the anesthesia, I give the anesthesia with a pump, and the catheter and the tip move sometimes in size of the vein, and you can be in trouble. You have to make sure that everything is well done, and the tip 2.5 centimeter from that area. What are the guidelines of the Society of Vascular Surgery and the American Venous Forum? The guidelines show that for the treatment of the incompetent great saphenous vein, the grade and recommendation is 1B. This is a couple of paper that was reviewing regarding about where we supposed to leave the fiber to make sure that we don't have a hit, to make sure that all patients will have the best that we can give it with no complication after the treatment. One of them is from the European consensus, who said that you're supposed to leave the catheter tip to 2 centimeters from the saphenofemoral junction. The another one is from Peter Glowinski and Monica Glowinski, showing that the catheter should be over there, 2 centimeters. Then there is a guideline for the third international consensus regarding about endovenous thermal ablation, and the recommendation was, after thorough consideration, that there should be leave the catheter 2 centimeters from the saphenofemoral junction. There are more stuff coming. If you are trying to do just an ablation with a radiofrequency, the recommendation is also 2. There are another one just coming from Pugioni and Monica Glowinski, a new one with more than 3,000 patients, regarding about where we're supposed to leave the laser tip, and we're supposed to leave that at 2 centimeters. Then we have that stuff. This is the Bible. When we are trying to read a book regarding about venous disease, Peter Glowinski have this beautiful book who show us all the techniques of all that we need to know about venous disease, and is endorsed by the American Venous Forum. In that moment was in Monaco when he signed a book regarding that stuff for me. This book said that you're supposed to leave the tip of the fiber at 2 centimeters of the saphenofemoral junction. Then I was reviewing one stuff from our friend Lowell Capney. Lowell was written a few years ago, where is the area and where we're supposed to leave the tip of the catheter. In the abstract said, increasing ablation distance peripheral to the saphenofemoral junction might result in a diminished rate of a hit. And the final idea came out after more than 2,000 patients with 2.5 centimeters, meaning that we have to move 0.5 centimeter from the saphenofemoral junction to make sure that our treatment is really good and with big trouble. Just to have an idea, this is the saphenofemoral junction, this is 3 centimeter ruler, and this is 1, 2, 3, and you have to leave the catheter in that area. To give you an idea, this is the way that we're supposed to have after laser treatment. No hit, no problem. The gray saphenous vein is without big trouble over there. This is a nasty picture showing that I hit number 2 with the small clot bulging to the saphenofemoral junction. And this is the question that I have for you guys. Will you go against the guideline? This is a nasty picture of thrombus going to the saphenofemoral junction. And this is a video remembering how bad can be for your patient a hit after you treat them. You have to remember that we are working trying to show and have the expertise behind our tool always. You will go against the gold standard of ABLT treatment. What is a guideline? A guideline is a document to show us the criteria regarding diagnosis, management, treatment, and is endorsed usually by the surgical specialty. Are you aware that your malpractice coverage would not cover you? Are you ready to hire a lawyer if you are in trouble doing moving too far from the saphenofemoral junction, the tip of your catheter, and having a hit after your treatment? Are you ready to lose your practice? Those are my questions that I have usually from the people who are trying to avoid the guidelines, trying to go and make a difference between what are we doing and what we're supposed to do all with the guidelines. And my final slide said, please, let's follow the guidelines and have a safe and successful outcome for all of patients. This is something that I would like to say thanks. We are coming out from the COVID seasons, and just to show you that we are moving forward here in Paraguay, I have already more than 10 cases done in the COVID, as the COVID safe guidelines, trying to improve everything and trying to change everything. I have to say thanks to Omar and Ayman to let me present that, and I hope everybody follow the guidelines to go through and to be safe always with this treatment in the laser time era. Thank you very much.
Thank you, Victor. It was a very nice presentation as usual. Now I think the time for the polling. Please, Mr. Khaled. Again, we'll ask the same question again. Ablation of great softness vein at the level of femoral vein is a safe procedure. After both presentation, you can put your comment. Are you with the motion, number one, or against the motion? Number two, please vote.
Can we, in the second, Professor Ayman, take a quick opinion of the panelists about this? Professor Loin Kapnik have joined us.
Sure, but I will wait till we see the results and see how much of our attendees are affected by both great talks. And I'll take the chance to announce I have many calls during the talks. They asking about the first virtual conference, AGVASC virtual conference. I repeat, it is a very good opportunity to join us as yes. Yes, thank you, Rag. You make some difference and they came to convince them a lot. Thank you, Rag. Now it's time for the panelists. I will start by Samer because he asked the question. Now I want to listen to you, Dr. Samer.
Okay, Tarag, thank you very nice for the presentation. And I'm the one with you that I think it is safe. And it's a new paper, I think, from Switzerland, from Dr. Spendi, showed, published recently, that it's safe to do ablation at the junction. But my question, what the advantage? If we are looking for decrease the recurrence, we have no study showed that leaving the stump increase our recurrence. We know with the surgery, if you leave a stump, it's increase your recurrence because of the new vascularization. But with the endovascular, most recurrence happen because of recanalization, nothing to do with the stump. So my question, even it is safe, what's the advantage? Do we have anything to tell us that really decrease the recurrence rate?
So
Let's start by Rag.
We have clear criteria for this, and they are so new. They have not been included in my earlier publications. So the reason is to protect additional branches of the junction from further disease. This applies only if hypertension in the iliacal femoral area is the driving force of the disease in that area. And I mentioned this applies for hard workers, also to office people who do nasty physical education after work and totally overstress their body. So this is a particular situation, maybe applying in not more than 30% of the cases. If the history of the local damage is different by congenital disease or acquired by stasis, I agree to everybody suggesting it's not necessary to include at femoral level because there is no local primary pressure problem. It's secondary. So it's another reason, another situation. And for a true solution, we have to diversify our attitude and base it on the analysis of the individual's hemodynamic situation.
Yes, thank you, Rag. I think I will take my chance to welcome Professor Antoniani and ask him what is his opinion.
Okay. I have a question to both the speakers. Compliments for the presentation. It's very interesting, the hemodynamic approach from Chris to decide the treatment is very important. What do you mean about the use of laser and foam sclerotherapy together? The svelte mode. It's a provocation.
It's no provocation for me since I heard about the Italian attempts of combining 2000 nanometer laser with common microfoam. I've been doing studies on that. And of course, the foam will provide a better status, a spasm status, to reduce the laser energy required. Yes. Nevertheless, I would not recommend the foam as a tool to prepare the junction, because in particular at the junction, foam is not reliable. It will escape to the deep venous system. Yes. And might have systematic collateral symptoms or even damage. So I think there is nothing better than handmade tumor sense for this particular reason.
Thank you. And Victor?
Yeah, my point is just like this. I would just always just go for the guidelines. I think that Dr. Rag told us that he can do it, but we have to go through the guidelines. This is the only way that we can be awake if you are in trouble after
the mic, Victor.
And oh, I'm sorry.
Voice is now. Increase the volume.
Are you listening now?
Yes.
It's better.
Okay. The final idea is we have to go with the guidelines. We have to go to whatever paper is already over there. And this is the way that we practice, and this is the way that we teach, and this is the way that we or residents have to know about what's going on already. There is no way to go for something that is not written. There is no way to go for something that is not in lines, and there is impossible to go for something that will let you in trouble after you have some kind of treatment. You have to make sure after you do a procedure that your patient is safe and you have the best result for him. This is my point of view.
Okay.
May I comment on that?
Yeah. Please.
This is a tremendously interesting topic. And I can see Lower Kalpnik smile. And well, this is not just relevant for ablation of the SFJ. It's relevant for all our discipline. And I want to put it clear. These words written, they are not the Bible. And they are not a law. They are guidelines. They are recommendations. It's not a duty to fulfill it, seen from the aspects of law. Of course, they have a meaning. And the meaning is that the magnitude of people using that particular method should follow the guidelines. But this counts for any beginner, for any fellow, and it's not a cage for the experts. We don't need a cage. The experts are the ones to bring the future, to bring the progress. Who else should do it? We can do it in studies. Of course, that's what I did. And that's safe because ethics committee has given its opinion on that. And we are never alone. It's always a group of scientists. And so these are different parts of reality. Many people say, oh, well, I will restrict my activities to the guidelines, and others will say, well, I think I can do better. Let's do some new study. That's two parts of the reality.
Yes, you have a point, and it's out of the IFO, yes. But let's go back to the debate. Dr. Kapnik, welcome, and thank you for joining us. Do you think it is safe to go as close as to the femoral vein when indicated?
So I would like to comment on both Victor's and Chris's talk. I think they were both excellent. They both had their point of views. I side a little bit with Victor at this point. Chris, I can tell you when I first started doing ablations in 1999 in the United States, I presented to the American Venous Forum the registry's data. I was hung out to dry. They thought I was ludicrous, that I was crazy, that I shouldn't be doing this. The point of fact is that when I started RF, I was at the junction with the old model. I think you have to be careful about what type of fiber you're using, some of the hemodynamics that you mentioned. And at the end of the day does it really matter? I know that you said, well, you get decreased E-hit, but I don't think that even matters. Then you talked about the anterior accessory in a prior discussion. But if the anterior accessory is refluxing and there's no symptoms, so what? So I think there are advantages of both. I mean, but I'm gonna throw this out at you. So what? So we can joust with windmills all day long. I think you need to follow the guidelines for most people to do that. But for people like yourself, I applaud you for going the extra mile, and you may come up with something. But I'm not sure that it's going to make a whole lot of difference. Thank you.
Thank you, Lawal. I would like to ask Khalid, Dr. Khalid from Al-Kafas from Egypt. What you like to do, Khalid? Do you think you would be safe to go as close as the saphenofemoral junction?
First of all, I would like to thank Dr. Rag and Dr. Kanata for the fierceful debate. I'm practicing endovenous thermal ablation for quite a good time. I was strict to the guidelines for 2 centimeters far from the saphenofemoral junction for most of the time I practice. But recently, I started to do ground zero ablation. I would like to inform that I use a radio frequency ablation, not laser ablation. I restricted to special cases. Maybe if I have a significantly dilated saphenofemoral junction or termination of the saphenous vein, this gives me an idea that the saphenofemoral junction is destroyed, terribly destroyed. So I try to be close to the femoral vein. Also, if I have a high insertion of the anterior saphenous vein, I try to ablate the saphenous vein more closer to the saphenofemoral junction. But I go with Dr. Kanata. Not all persons will do this. You must have a good experience in the ablation procedures. Also, you have to do a very good amount of tumescent anesthesia, maybe double the time, the amount you use it to not to injure the common femoral vein. This is my response to your question.
Okay. I think Victor want to speak. Please, Victor.
Yeah, we have to just make sure that in a big debate like this, that we have to state for the guidelines and go through what we will teach, because this is very important for the residents, it's very important for the quality. Besides that, I'm with Rag regarding about we have to introduce new kind of techniques, new way of treatment, but what will be the different point regarding about what's going on already and how will we finish the trouble? The final idea has to be we have to attach to the guidelines. This is the only way that the insurance will cover us, and if we are in trouble, we will be able to just have something or backup to just to make sure that we are doing the right things for our patient. Also teaching the residents. There are so many ways that we are trying to do and move, increase the amount of energy, pull back, pull down, trying to have better results. But what is the difference? There is no difference in the outcome. Why? You are, anyway, you are trying to make the vein disappear, the reflux going away. If you are moving further the vein, you can be having more amount of trouble in your practice. This is just the only way that I think, and this is the way that I will feel it.
Okay, I want to learn more from Raul. How far do you go, Raul, from the femoral vein?
Yeah, I want to pass two comments. I don't want to repeat the things what has already been said. It's a fantastic debate. The first comment is on technique and the safety. You see, in terms of technique, there is a special technique in way the tumescence was shown, because unless you are really good in an ultrasound, because once you give the tumescence, you are not able to see the tip of the laser or radio frequency fiber, where exactly it is. So sometimes if you are not experienced, then your tip could be in the common femoral vein and you can increase the risk of thrombosis. So I'll say that unless you are really well experienced in the normal routine laser or radio frequency, I will advise all the junior guys or the beginners not to try laser crossectomy. So this is my first comment. Second comment I want to pass is because we have, there are two very important points which Professor Chris Rag has also mentioned. One is increased pressure in the common femoral vein because of proximal pressure or high whatever reasons what are there. Second is the anatomy between the epigastric vein, anterior accessory saphenous vein, and draining into the common femoral vein. Because if on an ultrasound you see there is a huge amount of variation in the anatomy, all 1-2 centimeter, 1.5 centimeter away from the junction. And a lot of these patients, because it's a private practice, so the patients, they come back to us, we used to have a recurrence in the anterior accessory saphenous vein. Being in India, like 2 or 3 years later, if you have a recurrence in anterior accessory vein, people were not used to happy, because they used to get an ultrasound done, and on ultrasound it was reported so they will compare the previous report and they will come to us, doctor, the saphenofemoral junction was still incompetent. And it was very difficult for me to explain to them that SFJ is competent, but the drainage is not into the long saphenous, it's into the anterior accessory saphenous vein. And we need to do the treatment again, either with a foam or a laser. So then 2 years back, we shifted to laser crossectomy. So from last 2 years, we try to do most of the patient as a laser cross-sectomy. But I think Chris' study is really important, that why we need to ablate all the patient at the junction. Because I think what we can do is we can decide on the basis of the pressure in the hemodynamics in the common femoral vein. And second, on the basis of an anatomy. Because there are a lot of patients where the epigastric vein is draining into just at the beginning of the saffron femoral junction. And then there is a small 0.5 centimeter stump of the long saphenous. And then long saphenous and anterior accessory vein drains up. So in this way, I will not go to the junction. I will just close just below the epigastric vein. But at a point where the anterior accessory vein is draining along with the epigastric vein at a common point, there I will like to go at the junction, definitely. So basically, I try to occlude the origin of the anterior accessory saphenous vein.
Okay. You also think it is safe to go
Yes.
as close?
Yes, definitely, but only in experienced hands. So I will absolutely not advise the beginners to go there, because you will be absolutely fine if the patient does not get a thrombus, and if the patient has a recurrence 2 or 3 years later, it doesn't matter. But if you have a DVT and a pulmonary embolism, if the patient dies, nobody will be able to tell you anything, because why did you go there? You know, so that's a very important point. I want to make it here.
You have a point.
It's better to be safe.
Yeah. Yes, you have a point. Now I think I'll give the mic to Omar.
Okay, thank you very much, Professor Ayman. I have two questions to the two debaters. The first question, what is your opinion about using double layer laser transradial catheter, which means double ring transradial catheter? So this is a question to Professor Kanata, Professor Rugg. If you like to start, Professor Kanata, about what is the difference between double ring transradial fiber.
When you are choosing the tools that will give it to you the best result for your patients, sometimes the best fiber are the ring fibers. After you have the second ring fiber, we are increasing the way that the amount of energy are going to the wall of the vein instead of going to the tip. And we are having better results. What mean with better results? The pain is less, and we have less amount of hematomas after we do the treatment. But there is no big difference between one ring and two rings. But there are the problem is in the amount of money that you require for each patient. For a double ring fiber that you will able to use only in 1 or 2 patients, you are losing between $200 to $250 for each fiber, meaning that you will not able to get the money that you require for the procedure if the procedure is not covered 100% for the insurance agency. In my country, sometimes they are covering just for some amount of money that sometimes not covering the double ring fiber. It's just for the bare fiber. And I use it without big trouble. This is my experience, but I don't know what Rag said. And also I would like to hear Lo what said about the double ring, because he has more experience than me in double ring laser treatment.
Okay, Professor Rugg.
From my side, it's a comment on physics. So splitting the energy to 2 rings has a certain intention. This intention is that the first ring and its emitted energy should induce a spasm and a little bit of effect. And the second ring, well, this should now adhere closely to the vessel wall and have no distance to the endothelium, and thus with low energy have a lot of effect. So this is the theory. In practice, if you're using tumescent anesthesia in a proper way, there will be a total adherence, a total connection between the catheter or the probe and the vein wall. So there is literally no advantage of the two-ring. If you're using the two-ring under general anesthesia without tumor sense, well, there's a theoretical advantage, but I would nobody advise to try that way, because tumor sense, we know all about this, improves the safety and the effectivity in a way which is uncomparable. So there are theoretical advantages, but not in practice.
Okay, Professor Lloyd Kabnik.
Chris, you know I'm coming after you again, but it's all in fun. So when you talk about physics, the single ring fiber has always had a lower power density than the forward firing jacketed fiber that we have here in the United States. Therefore, you need more energy in a single ring fiber than a forward because of the power densities. And therefore it transmits to higher watts and a little bit more energy because of the size of the rings. But the radial fiber in large has a theoretical advantage because it goes directly to the wall. When you talked about spasm with the first ring, I would submit to you that the vein goes into spasm surely by the push of a catheter, and we've seen that all along. Second thing that didn't make sense to me about a double ring fiber is that the power, which is set at 10 watts, is distributed amongst both rings. So you get 5 watts on each, and it's not really an additive factor. So I think to me, it was a marketing device.
Yeah.
I think that the single ring fiber is the best as we go there in terms of what it's being used for. But I would submit to you that the Never Touch fiber, which is a straightforward jacketing fiber with an angle of 30 degrees, has never been shown to be any better or any worse than the single ring, because there's been no head-to-head trials on it.
If the double ring was an American product, we would all be using it.
Well, if it was a double ring fiber, I don't think anybody would be using it.
No, just for the reason that you have the talent to put out the tiny little difference to make us believe that it's worthwhile paying 250 more bucks for it. But since this was a German product, it failed. In my opinion, it failed.
Well, I wasn't coming to the fact of making it a nationality. It was just the fact of the matter is we're talking physics. But thank you for your joust.
Yes,
Hyman, can I pass a small comment on this, please? Because I always thought there is a big difference. You see, if you are using a single ring and you're using a continuous mode, there is no difference if you're using a double ring or a single ring. But if you are using a method of having a 1 centimeter withdrawal technique, like an interrupted technique, then double ring is better. Because here, if you are pushing the energy in a 1 centimeter area, so the single ring fires the energy at one level, and the double ring will fire at another level, 2 levels. Because the amount of energy what you require is not enough. It's enough. 5 joules is enough. And what we were delivering were 10. Because if there was, because there has been a lot of studies where the single ring and the double ring did not show any difference in the vein closure rate. So why we were giving more energy in single ring, and in double rings, we were giving less energy at 2 points. So I feel that if you are using a continuous method, then it's okay. You can use anything, but I think
yes, you have a point, and I think as
he does.
I don't know, because there are no studies to support.
yes,
exactly.
And as Lowell said, there's no head-to-head study. I think this will be the time for head-to-head study. Get the difference. The mic again with Omar.
Okay, we got a question from the attendants also. Dr. Katerina Zenovica. If we can bring her and unmute the mic, she can ask the question herself. Dr. Katerina Zimivoda. Can you open your mic and ask your question? will give it another few seconds to see if she's unable to open the mic or not. It seems there is a problem with her mic. I'm very sorry about that. And let me take this final question. Which is the best laser wavelength to be used in great saphenous vein at the phenofemoral junction? That's a tricky one. And let us start by Professor Rugg and Professor Kanata. So what is the best wavelength? Single answer, single number.
1470, because it's a compromise between 980, which does some coagulation, and 1940, which has the best immediate effect, but not provides closure immediately.
Okay, Professor Kanata, what is the best wavelength?
I have the pleasure to use the 810, the 980, and the 1470. There is no big difference between 980 and 1470, but the 1470 has a minus pain after the treatment, and the patient has a better outcome of follow-up after you have the 1470. That's why I will choose 1470.
Okay, Raul, I know that you are interested in reading about laser technology. So what is your best wavelength?
You see, I believe, if you look into the laser rates, you take from 810, 980, 1470, 1940. If you have an head-to-head study, they will have the same closure rates. Because you see, all these, I feel, when you come to 1940, the basic thing was that it has got a more water absorption as compared to hemoglobin. Okay. So this was the basic concept. But when you look at the 810, and you look into the chromophores, it was mainly absorbed by the hemoglobin and the least by the water. But still, it could give us one of the best closure rates because it was low at the water curve. But still, it could give one of the best closure rates. So I personally feel if I have to choose out of all, 1470 will be the single answer, because there was 1810, 810, and 900. So they used to have more ecchymosis as compared to 1470.
Okay, Professor
because
Sam.
This is because there was a reason for that, because 810 was a shorter wavelength, so it will have more effect.
Okay, it seems a very exciting question, so I will take all the panelists at the time. So let us start by Professor Samer Qusair. I know you have very big venous practice in Saudi Arabia, plus your huge arterial practice. So what is your best wavelength? If you can unmute yourself. We can't hear you, so you need to unmute.
Sorry. Yeah, I agree. I think 1470 is the
1470.
best. Yeah.
Okay, Loyal Kabnik, your best.
I published a study looking at wavelengths and fibers, and it was clear. It was in JVS VNL, and it was clear to me that the fiber was more important than the wavelength in terms of postoperative pain and bruising. Together, the 1470 plus a covered fiber was superior than an 810 and a bare tip fiber. So don't forget about the fiber. And I think the fiber is the equalizer for all wavelengths.
Yes.
Professor Khalid Al-Affaz from Cairo University.
I have no good experience with laser ablation. I use RF, but I think 1470 is good enough. But I want to raise a question. If there is any future for the microwave ablation in thermal techniques? To all the panels there.
We'll take this question after we're finishing the wavelength dilemma. So let us take the opinion of Professor Antoniani. What is your best wavelength? If you can open the mic. That's it.
No, I don't have experience about this new laser. So.
Okay, and Professor Fabrizio from Brazil.
Yes, 1470. Combined with the good laser fiber.
Okay, that seems it seems unanimous wavelength. So that is quite nice conclusion. So let me take the quick opinion about the microwave ablation. Is it going to be a future technology, outweigh laser or not? And let us take a quick recap of the panelists. Professor Rugg, what do you think about microwave?
Well, it's good to have a microwave in the kitchen. Well, all these devices can't beat physics. And our problem is still to apply energy to the endothelium and parts of the media, but not harm the adventitia and induce bad feelings. And microwave cannot solve this problem. So it's another tool. It's not bad. Everybody is free to use it, but it's not a miracle and it's not a real new chance.
Okay, Loyal Kabnik.
Too early to tell in
Yep.
terms of microwave, but I can't. But we'll see.
Okay, Professor Samer Qusayr, microwave ablation. What do you think?
You're talking about high frequency ultrasound or microwave?
No,
two
we're speaking
different
about
ones.
microwave.
No experience. I read about it, but no experience, so I cannot comment, sorry.
Okay. Professor Kanata, what's your opinion about microwave? Do you have it in your private clinic?
The same that Dr. Rugg. Things we are unable to target in the best way the endothelium of the saphenous vein, we will never be able to fix it. And I think from now on, the thermal treatment with laser are the best, with the best result from now on. Let's see in the future what's going on and what are the results, and then we will change everything.
And Raul, Professor Raul, what do you think about microwave?
Yeah, we started using microwave around a year back, and so we have done around 20 cases and got a follow-up around 1 year now. And if I have to advise to the newer people, so I think a microwave should not be bought in the first, and should be the first machine. The reason for that is very simple, because one is, if you want to, let's say, do the crossectomy, it's very difficult to do with a microwave because you cannot go at the tip because it's difficult to control. Yeah. Second is, it is much more painful than the laser. So you require much more tumescence than the laser machine. Third is, even the company, what we are using is a Chinese company, and they still don't have the parameter setups. So when they were, the guy who is the CEO of the company, he came into our office and we were doing the cases with him. He was still confused with the fixing of the parameters. So we did 10 cases with one parameters, 10 cases with another parameters, and the higher parameters all were closed, but the lower parameter out of 10, 4 opened up on the follow-up at 3 months. So I think the parameters were still not fixed. Fourth is, we still don't have the long-term studies available anywhere in the world in the literature. And the fifth is, if you want to use that device for perforator closure or a short stump or short saphenous vein, or you want to close a very short segment, it's not possible.
Yeah. And Professor Ayman Fakhri, I know that you are a big enthusiast for microwave and you are the first one to buy it in Egypt. So what's your opinion, Professor Ayman?
Really, I don't have big experience, as I did about less than 15 cases. But my little experience showed that it is more or less the good method. Post-operative pain is very nice regarding to the laser. There is very few pain post-operatively. The catheter is more tough, and it is not easy to go through the veins. But in general, with follow-up about 6 months, it's a nice procedure.
Okay, and Professor Angelo, what do you think about microwave ablation? If you can unmute yourself, Dr. Angelo. Yes, what's your opinion about microwave ablation?
Well, I have no opinion about microwave ablation, but I'd like to make one comment, if you allow me, about all discussion.
Yes, please.
I am introduced me many years as a serial killer of saphenous. I killed Safinas along more than 30 years. And now I am penitent. I am penitent. And I am avoid to destroy the Safinas anyway. Okay. And I perform a lot of surgeries, make just a femoral ligature. It's very important. Now I am seeing that it's not more important. That is changed completely. One discussed if we need to put 2 centimeters below or put into femoral junction or 3 centimeters below. I think this is not important, nothing, absolutely. The important is why we destroy the saphenous vein. If it is not the responsible for the saphenous, for varicose syndrome. The dilatation is consequence and no cause. But this my just comment. I know the discussions about the delays, but only my point of view. Thank you very much for the opportunity to talk.
No, absolutely, very welcome. I'm Professor Luigi Antingiani. What do you think about microwave ablation?
I agree with Chris Rack.
Yeah,
because it's
better in the kitchen.
It's a particular condition, yes.
Okay, and lastly, Professor Fabrizio from Brazil.
Actually, I'm totally open-minded. I think we all should be, but I'm also a big fan of facts, regardless if it's microwave or if it's ground zero. So this is something that we need to be attached with. So I think it's a promising technology, just as the ground zero can be a very good technique in the future, but I also need facts.
Okay, with that final comment, thank you very much for all this interactive discussion and very nice tips and tricks. And the mic is back to you, Professor Ayman.
Thank you, Omar. Thank you all. It was great fun. We all enjoyed your company. Thank you for the great speakers, Dr. Fabrizio Santiago from Brazil, Dr. John Rack from Germany, and Dr. Victor Canata from Paraguay. Thank you for the great panelists, Dr. Angelo Scuderi, Raul Jindal from India, Dr. Samuel Qusay from Saudi Arabia, Dr. Khalid Al-Kaffas and from Egypt, and dear professors Antoniani from Italy and Lowell Kamnik from United States. Thank you all. I have 3 announcements, very important announcement. Today, just now, the time is closed for participants for the competition for Young Vascular Fellows. We have a lot of abstracts and all of them are fine. And the scientific committee will start its job starting from now till next Thursday. And we get, according to their opinion, 5 or 6 presentations to be presented on June 19th. And it will be a very good chance for fellows to present themselves along the whole universe. It will be a good chance to talk and express their ideas. Second announcement, please mark your calendar for the great webinar meeting next Friday. We have Armando Lobato from Brazil and Professor Hani Zaid from United Kingdom and Professor Murad Salam from United Kingdom next Friday on 7 p.m. And lastly, please join us on first virtual conference, AGVASC 2020. It is the first time to have your avatar discussing, sharing, joining, make fun. It will be very good event and very good chance to make avatars sharing our lives. Thank you. Thank you, Omar. Thank you, Prime Partners, for doing all the job for us. Thank you and have a good night.
Thank you. Good night. Bye-bye.
Thank you. Bye-bye.
Bye.
Bye-bye.
Thank you. Bye-bye.